Assalamu alaikum. So in this video, we'll be talking about the MRI scan of the lumbar spine, how to read the lumbar MRI scan, how to identify a normal MRI scan of the lumbar spine. And then in another video, we'll be talking about the most common pathology in the lumbar spine imaging, which is a lumbar disc prolapse. But for you to understand this very well, you have to keep in your head a visual image about a normal MRI scan. So in this video, we will cover this and I will show you easy tips and tricks to read this very smoothly and very quickly. I am Mohammed Raz and this is your knowledge platform about the brain, spine and beyond. So as you can see in this picture, we have here an MRI scan of the lumbar spine. This is a sagittal view where we cutting like from the side and like cutting like this and looking from the side. And what you can see, or what we need to look at, this is a T1 image. How did we know that? Because the CSF is not bright, is not white. So if the CSF is bright or white, that will be a T2 image. So that's a T1 image. And the T1 is really useful because you can get the important anatomical landmarks from this image. So first of all, looking here, I would look into the alignment of the spine. So I would draw a line like here, and I can see here, this is kind of a smooth line all the way anterior to the spine. If I look posterior to the vertebral bodies, again, that looks like a smooth line. Again, around the spinous processes, I can see that this is a smooth line. So what we have here is a vertebral body, another vertebral body, and in between we have the disc prolapse, the disc. Another vertebral body, another disc. And what we have here is the thecal sac containing the end of the spinal cord and here the start of the cauda equina. And what we have here is the spinous processes extending like this, and this is another one. And in between, this is the interspinous ligament. Another spinous process, another interspinous ligament, another spinous process, and another spinous ligament. What you have here, which is white, that's not CSF. That's basically some fat posterior to in the spinal canal. So if we look here again, looking at the signal within the disc, it looks like normal signal. That kind of grayish color is like a normal signal. I can't see like a proper disc prolapse, like something bulging out of the disc area, and we will confirm that as we look into the T2. Also looking posteriorly around the spinous processes, all looks very well aligned. There is no kind of stepping or abnormal alignment. And also in terms of the vertebrae itself, all the vertebrae looks like square shaped. So there is no kind of a collapse or any change in the shape of those vertebrae. But also the signal within the vertebrae itself looks normal. So that's what we look out for. What's also important here is to look at the spinal cord. So the spinal cord, we look where it's ending. As you all know, the spinal cord usually ends around kind of L1, L2 level, and then the start of the cauda equina. So if the spinal cord is lying below that level, that means that the patient might have a problem with a low-lying conus, which might be for various reasons. That's not the scope of this discussion here. But here we're looking at, I think that's the end of the spinal cord here, and that's basically the kind of the conus of the spinal cord, or the conus medullaris, and here is the start of the spinal cord. And then we count from down all the way up, 5, 4, 3, 2, 1, kind of 12. So that's around kind of T12 as the level of the conus. So that looks normal. And then what we have to do is also to go right and left. So going to one side, what we look at here, that's the vertebral body and that's the pedicle on one side. That's a vertebral body and that's the pedicle. That's the vertebral body and that's the pedicle. And what you're looking at here is basically this teardrop kind of shape. And that teardrop represents the foramen. This is the area where the vertebral foramina are opening up, where the nerve roots are going out like this. And as you can see, the little kind of hypo-intense area here is the nerve root with some of the fat around it. Or in T2, we can say that's probably CSF around it. And what you're looking for is basically making sure that this looks like this shape, as you can see here. That's the normal shape. It looks like a teardrop that shape. If that shape is abnormal or it's squashed or you can't see the fat or you can't see the CSF, that means that there is some sort of pressure here. So all of those looks fine, and then I move into the other side, and again trying to get a feel and seeing all of those teardrops all the way through all the levels, and all of these looks normal to me. Then what we do is that we move to a T2. How do we know this is a T2? Because we can see the white signal of the CSF, and that means that's a T2. T2 is very good because you can see the disc prolapse, you can see other pathologies and any compression of the nerve. So similarly, we have already defined the alignment, and there is no kind of abnormal shape of the vertebra or abnormal alignment. But also look here posterior to the vertebrae, that you can see this is all going in a smooth line. The CSF looks like going in a smooth line. I can't see any disc prolapse coming out. There's nothing coming out of the disc that's causing pressure on that CSF. Similarly, you can see here the spinal cord or the conus medullaris much more clearly, and the coda equina, which is the nerve roots, are going all the way down through the fecal sac. So similarly, we kind of looking at the repeating the same process again in the T2 image. We will go to the again to the sides to see this teardrop, where you can see the nerve root and the CSF surrounding it, and we will just move the image so that we can see again the teardrop, the nerve roots all look fine. So there is no kind of foraminal pressure or on the nerve roots. We will go to the other side, and again looking here at the nerve roots, which looks fine. Then it's very important to look at the axial imaging. You go do that with the T1 and the T2. What I will do here is just the T2, just for the sake of the time. And what we looking at here, basically in your PACS system, you compare both at the same time. So you have a sagittal T2 and an axial T2, so that you can correlate which level to what level you're looking at on the axial imaging. And what you look at through here, let's take that level, for example, is what we have here is the vertebral body. And what we have here is the lamina on one side, another lamina on one side. That's the spinous process towards the back. So that's posterior, and here is anterior. That's towards the abdominal cavity. This is the psoas muscle, big one here, and this is the other one on the other side. And here is the paraspinal muscles on each side. So that's one side on the left, and that's the other side on the right side. What we have here is all fat. That white thing here is all fat, the subcutaneous fat for this patient. Inside is the spinal canal. And what we can see here, the white is the fluid, which is the CSF. And the dots are basically the coda equina. Those are the nerve roots. And if we move slightly here, at each level, there will be a nerve root coming out through the foramen. That's similarly the foramen that we have seen in the sagittal image. So one nerve root on one side and another nerve root on the other side. And you can see that the nerve roots are lying freely in that space. They are kind of they kind of swimming in that space. If you can't see that image, this means, if doesn't look like smooth or regular or rounded like that one, or slightly triangular, if it's compressed or pushed to one side, then means that there is something wrong, either a disc prolapse or spinal canal stenosis. You can also see here there's kind of a hypotense line here, hypointense, that dark line here and the other dark line here, that's the ligamentum flavum. And the ligamentum flavum is very important to appreciate, because if that flavum is thickened, that can lead to canal stenosis, lumbar canal stenosis, especially in older group of patients. What we also have to look for is the facet joint. So you can see here that's the facet joint, which looks like a hypointense part here and here. You can see that looks like a joint. It's very easy to recognize on this axial imaging, and you have to see that is there a signal coming out of this? Means that is it white? That means that there is something wrong with this facet. Is this facet looks like in place? Is it overgrown and kind of hypertrophied and causing pressure on the foramen or the rest of the spinal canal? So you do the same process at all levels. And as you can see, the coda equina or the nerves are all looking free in all the levels, which looks normal to me. Again, that's another facet joint here. That's another facet joint on the right side. And also what's important is to look lateral. So laterally means that's the center here, and more lateral is basically the lateral recess. So you need to identify, is there a pressure on the nerve as it's coming out of the spinal canal towards the foramen that's causing a lateral recess stenosis, or pressure on the nerve root on the lateral aspect. So as you can see, it's very easy to recognize the normal anatomy within the lumbar spine MRI scan. Just keep a structured way of looking into the MRI scan, mainly looking at the sagittal T1, the sagittal T2, and the axial T2. Try to have a structured way of looking into this picture. What do you need to look at? And then once you see multiple normal MRI scans, you can do this online very easily or by repeating this video multiple times. And then you can see the once you see an abnormal picture, you can recognize it easily. And that's what we're going to do in the next video, where I'm going to show you multiple MRI scans of patients who are having different types of disc prolapses, so that you can appreciate what's abnormal in comparison to what we have seen today as a normal MRI scan. Please share and subscribe to our channel, because this helps us a lot to that our content can reach a wider audience. Make sure also that you subscribe to our newsletter, which is coming out weekly, covering a lot of things within the neurosurgical community that will help you in your career, and also to network with others, and follow us on our LinkedIn page. See you.